colleagues, in partnership with the Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse et Transplantation, and the Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor John William McEvoy in Galway, Ireland, in order to discuss the 2024 guidelines of the European Society of Cardiology on the management of elevated blood pressure and hypertension, which have been published with Professor McEvoy as first author. Dear Bill, we're blessed to host you tonight.
Thank you very much, Dr. Heine and the rest of the Marcus at Home team. It's an honor for me to present the guidelines and discuss them with you all.
Dr. McEvoy is, as Gunnar alluded to, Professor of Preventive Cardiology in Galway, Ireland, who is a particular specialist in hypertension research, being also a medical research director of the National Institute for the Prevention and Cardiovascular Health. He holds a master's degree in cardiovascular epidemiology from the Johns Hopkins School of Public Health. And his research focuses on testing novel biomarkers and the risk and clinical epidemiology with special focus on hypertension and atherosclerosis. So we're very happy to hear your insights. And we do have some questions if we have some time left after your presentations. Again, thank you very much for coming and joining.
Yeah, my pleasure. Thanks for that introduction. I spend 50% of the time looking after patients, so I'm involved in both the academic and the clinical side, which I think is important with respect to creating guidelines. So yeah, I'm going to talk a little bit about these 2024 ESC guidelines on elevated blood pressure and hypertension. I have about 12 minutes worth of slides, and then we can maybe have a conversation. I don't have any relationships with industry or other conflicts of interest to disclose relevant to the guideline. This is the guideline. It was published now 6 months ago in the European Heart Journal. It is free to access, and something I would encourage viewers to take a look at if they have the time. I'll also say, in case I forget to say later, that the guideline also has a pocket guideline version, which is a very abbreviated version, which is also available online. And there's an app that you can download to your phone, which includes the pocket guideline and some interactive app-based protocols to follow that would be consistent with the guideline recommendations. But this is the full document, and we're pleased to have at least representation from one nephrologist. I understand this is a largely nephrology audience. So that's Charlie Farrow from the UK. Your balanced representation of stakeholders and task force members according to biologic sex. And not just cardiologists, but again, a nephrologist. We have a geriatrician, GP, endocrinologist, neurologist, psychologist, and 2 patient representatives on the task force. So the prior 2018 guideline, which was published jointly with the European Society of Hypertension, had 7 categories of for blood pressure. We decided to try to simplify things, and we proposed these 3 categories according to office blood pressure, and that is non-elevated, so that's an office less than 120/70. Elevated is between 120 to 139 systolic in the office, and you can see the diastolic numbers. And hypertension, we chose to keep the traditional definition of hypertension greater than 140/90 in the office. There were some conversations about whether or not we should reduce the threshold for hypertension like they did in the 2017 US guidelines. We chose to keep the 140/90 threshold, largely because this is the threshold above which almost all patients, once confirmed, should be considered for treatment. It's in the elevated group where there's some nuance to identifying some that may benefit from treatment. But because the hypertensive group, largely speaking, will all benefit from treatment as long as it's confirmed hypertension, we kept this cutoff of 140/90. We do obviously focus on some confirmation, either a repeat office or preferably an out-of-office assessment. So not to make a diagnosis based on one blood pressure, which of course is not good clinical practice. Like I said, we do recommend out-of-office for diagnostic and for ongoing management. We give a quite strong level of recommendation, class of recommendation with a strong level of evidence. So 1B, reasonably strong. There's no randomized trials that show that you need to use out of office, but we know that out of office measurements are much more accurate. They're more prognostic, and they allow for less patients to be treated because you've got less misclassification of blood pressure, and you can obviously understand a little bit about the white coat and masked hypertension phenomena. For our categories, our 3 categories, we provide out-of-office equivalents for these various different categories. I've told you the office measurements. The out-of-office measurements are similar, slightly lower threshold for hypertension with out-of-office than with office, and that's based on numerous correlation studies. We get into why the office tends to be higher than the out-of-office, but we know that these correlations are quite consistent. I will say that the non-elevated category is pretty much the same across the board, and you see less of a differential in the office and out-of-office reads when you have blood pressures that are in that non-elevated range. It's more in the hypertensive range that you can start to see a discrepancy between the office and out-of-office. Nonetheless, we provide these thresholds because we again like to see office being done where at all possible. We realize it's not possible in all medical services and in all countries, but if it is possible, it's preferable to have some out-of-office information. You might ask why we're interested in these 3 categories. You might also ask why we didn't call the non-elevated blood pressure group normal or optimal. This is a question that comes up quite a bit. And largely speaking, the reason we didn't do that is we didn't want to get into a philosophical debate on what normal blood pressure is. And there are quite a lot of philosophical debates, and we could probably spend a whole hour on how you define normality with regards to blood pressure. Is it based on normal distribution? Is it based on prognostic information? Is it based on anthropomorphic information from evolution? We know that risk, at least from a prognostic epidemiologic point of view, starts to increase at systolic blood pressures probably as low as 90, but certainly by 100, you start to see some increased relative risk. So should we say normal is less than 100? It's very difficult. So we decided to say it's just non-elevated. We don't need to be fixated on normal. What's normal, what's not. For the elevated category, that 120 to 139 systolic, like I said, we want to see if there are some patients there that may benefit from treatment, and that's based on trials. But why is this group important? Well, epidemiologically, we know that about a third of cardiovascular disease events overall, this is based on disability-adjusted life years in the global burden of disease, but about a third of the disability-adjusted life years attributable to CVD occur in adults who have blood pressures in this elevated category, this 120 to 139. And that's not too surprising because that's where most people live. If you looked at a population distribution, this is not a population distribution. This is a distribution of disability adjusted life years. But if you looked at the population distribution, most people are in that 120 to 139 range. And so there are a lot of events in this range just by a function of the many people that are walking around with blood pressures in this range. But if we were to ignore these people, especially in the context of the trials I'll discuss, we're ignoring an opportunity to potentially impact on about a third of cardiovascular disease events. So we felt this should not be taken lightly. That being said, this is a heterogeneous group. Again, the yellow or the orange box is the elevated blood pressure range. These are data from the UK, but you can replicate this with data from pretty much any Western population. And the long story short is that if you look at the yellow box or the 2 bar graphs in that yellow box, there's quite a bit of light blue coloring there. And that's the people who have a less than 10% estimated 10-year risk for cardiovascular disease. So low risk individuals. And so most people in the elevated group are low risk, low estimated 10-year cardiovascular risk. And these are not the patients we're looking to treat in this group. We're looking for that kind of more needle in that haystack, that higher risk patient who may benefit from treatment. So we have to try and choose some method to pick these patients out for consideration of treatment in this elevated blood pressure group, and that is cardiovascular risk estimates. For the hypertensive group, less of the light blue, and I would argue, outside of a 10-year time horizon, for a 30-year time horizon, there'd be no light blue. These patients with hypertension are all sufficiently high risk to warrant treatment as long as it's confirmed. Certainly over a longer time period, even in the young, I would say that's true. So what about the trials? I mean, there have been a number of trials, and some of them have been recent. And in that context, I think we're lucky in hypertension that there's a fair amount of activity in the field. And these are just 3 trials, but there actually are. There's at least one more trial, a trial called BP Road that came out recently. But all of these trials enrolled adults who had blood pressures over 130. And to enrich that trial population in events, they not took everybody with a blood pressure over 130. You needed to have a blood pressure over 130 plus risk. So either established cardiovascular disease, low EGFR, or a Framingham risk score of greater than 15%, say for sprint, which equates to about a 10% risk by the score 2 equation that the ESC currently recommends. The SPREET, you needed to have risk factors or established CVD. And the Chinese Rural Hypertension Control Project, same. To get in for blood pressure over 130, you needed risk. And that's true for BP Road as well, which was a diabetes trial. All of these trials, by the way, showed benefit for more intensive blood pressure targets in these patients with systolics greater than 130 on entry. So, in summary, the 3 categories boil down to non-elevated blood pressure, no treatment. Obviously, lifestyle, you want to maintain that non-elevated status, be great. I'd love to have a non-elevated blood pressure. Unfortunately, I don't. Elevated blood pressure, it depends. And it really depends on risk and the follow-up systolic blood pressure. If the risk is high, I'll show you how we define that, and the follow-up systolic is greater than 130, then we do recommend treatment. We want to make sure we didn't miss people who had masked hypertension in this elevated group. And so, the trigger to consider a risk assessment and out-of-office measurement is 120 to 139, but the trigger to treat is a sustained systolic over 130 after 3 months of lifestyle in the context of concomitant high CVD risk. And then everybody for hypertension should get treated as long as it's confirmed. This is a kind of abbreviated, you can see I cut things a little bit here, but I try to abbreviate this to make it a bit more user-friendly, if you will. I think maybe the figure we came out with suffered from the old guideline problem of people wanting to have everything included and yet also have it be simple, which is kind of a dichotomy. But anyway, this is a simplification of our risk assessment for the elevated blood pressure group, the 120 to 139 systolic. By the way, you'll notice I use the term systolic mostly. I think that's really the main determinant of treatment, especially with these more intensive targets. But here, again, if you're in that elevated group, first step is kind of low-hanging fruit. Do they have established CVD, moderate severe CKD, indicating high cardiovascular disease risk? Hypertension-mediated organ damage, diabetes, or FH. If they do, you can quickly say, okay, these are high-risk people. After 3 months, if it's still over 130 systolic, probably should treat those patients if they're agreeable. If they don't have the low-hanging fruit, they don't have the obvious high-risk conditions, then a 10-year risk estimate using the score 2 or score 2 OP, older persons, is recommended by the ESC. Now, this is an ESC equation, and I'm not going to say that it's absolutely required this has to be used. I don't know what you guys use in your own practice or locally, but there are other risk equations. I think this is one of the better ones. It's certainly most contemporary and is calibrated for European populations. But there are other risk scores that people use, and I'm not going to get into an argument about which one is best. This is what we recommend. If it's over 10% and you're in that elevated group, and after 3 months, it's still over 130 systolic, then treatment. If it's less than 10%, largely you could say, fine, these patients can be monitored and recommended for lifestyle. So that's the two-step kind of core of our risk assessment recommendations for this elevated blood pressure group. Now, there are some optional things, and this is again where the figure, this is a more complete figure, where you could consider for an intermediate risk, 5 to 10% 10-year risk, you could consider some risk enhancers or risk modifiers or some risk tests. And I won't get into that for today, but there are some additional things that some people have particular interests in, and especially clinics may be running some of these tests. These are optional. I would say we give them a class 2 recommendation, not a class 1 like step 1 and step 2. Okay, so how about treatment? Well, we say if you're elevated blood pressure, that's the 130 to 139. Those are the people who may be treated if they're, had 3 months of lifestyle and they're still in that range above 130 and they have high risk, high cardiovascular risk. Then we say initial monotherapy. For those who are hypertensive, greater than 140/90 after confirmation, we'd say initial monotherapy for those who are moderate, severely frail, older, have orthostasis. But for most who are well and not over 85, not moderate, severely frail, for most hypertensive patients, we do recommend starting with a low dose double combination. And those options are kind of 4 first line meds, if you will, are ACE or A or B, calcium channel blockers, diuretics. And then if they're not a target with a low dose combination, a low dose triple is recommended, and then titrate to full dose. If there's not a target on a full dose triple, then you're talking about resistant hypertension. And there we recommend the kind of bottom of that flow chart assessment of adherence, some kind of assessment to see if this is true resistant hypertension. In most cases, it's not. It's apparent because of non-adherence. But also a referral to a specialty center and consideration of spironolactone as the 4th medicine in this protocol. At any point in the process, we say that beta blockers are perfectly reasonable to add if there's compelling indications. There's a bit of debate about this because the ESH came out with a guideline in 2023, which is regrettable. There's 2 guidelines in Europe, but the 2 societies parted ways for the most recent guideline, and there's a long story behind that. But we do not recommend beta blockers as first-line treatments, and that's not because they're not good blood pressure meds. It's largely because they're probably the least well tolerated of the main line medicines, and they also may have a less effect on stroke outcomes, although we could get into a debate about that. Largely speaking, we didn't change them to a first line because there was no real new evidence for beta blockers after the 2018 guideline, and so we didn't feel there was sufficient evidence to make a change from that 2018 guideline, which said the same thing about beta blockers, only for compelling indications. One other thing that has generated some attention, I would say, and we could have a debate about this as well, but it was our recommendation to consider assessing patients with hypertension for allosteronism, primary allosteronism, and that is a somewhat controversial, I would say, because that requires the systems be in place and the learning and specialty expertise be in place to actually deal with this information. But at the same time, it is true that primary allosteronism is very common, and the more you look for it, the more you find it in these patients. And let's face it, it is something that is that can focus the treatment and make treatment more personalized. We're all about personalized medicine nowadays, and it's kind of odd that we would be potentially ignoring 10 to 20% of hypertensives by not assessing them for this very common comorbidity. It's of course a bit complicated though, because the medicines can somewhat interfere, and that's where it gets a bit more controversial. But we did recommend it at a class 2A to consider screening for allosteronism in patients with hypertension. How about our targets? these are our targets. It's pretty simple, really. We say a target for all those who are being treated. So if you're getting a blood pressure lowering medicine for hypertension, or if you're getting it for elevated blood pressure, high risk, and sustained systolic over 130 after 3 months of lifestyle, uh, you should try to achieve a on treatment systolic blood pressure 120 to 129, and that's a class 1. We gave a class 2 for the diastolic, and that is in a scenario where, say, somebody's systolic is at target, so 120 to 129, but the diastolic is above target, so 70 to 79. There, it's a very weak recommendation. You could consider further treatment. But I would say, in large part, if the patient's at a systolic of 120 to 129, it's probably less important to worry about their diastolic at that point. We do say that 120 is the optimal point on this range, and that's because the trials, and I've showed you some examples, but they've all consistently shown benefit for a target of less than 120. Now, what was achieved in the trials was actually 120. So you say less than 120, people achieve 120. But that was an average. There was still half the people less than 120, but also half above. Anyway, the average was 120, and that's where the evidence is. I will also say that, as with all guidelines, all blood pressure guidelines, we emphasize the need to measure office blood pressure in a standardized way properly. But let's face it, that's been recommended for decades and it doesn't happen all the time. So we didn't say everybody should reach 120, which is what the evidence would suggest. We gave some wiggle room with this range of 120 to 129, acknowledging the fact that blood pressure in the office is not always done in a really standardized, proper way. And the data would indicate that when you do it more routinely, as compared to a standardized, you get about a 5 to 10 millimeter higher systolic. So that's why we get the wiggle room of 120 to 129. We also like to think the guidelines are very pragmatic. We're not trying to come from on high in our academic towers and tell clinicians how to treat their patients when the clinicians probably know more than we do. And we say that if you're not able to achieve a 120 to 129, that's fine. That's perfectly reasonable. You've tried and you could back off and target a systolic that is as low as reasonably achievable. So this whole ALARA principle, which of course comes from radiation medicine. And we can also be more lenient and go as low as reasonably achievable, not worrying about having to get the patient to 120 to 129 in patients who are older, frail, or limited lifespan, orthostatic, and so on. That's really it. We do say ambulatory out of office home blood pressure is desirable for assessing the target is being achieved, and that we're not over treating or under treating based on just an office. But we recognize that's not always possible. We have very good data, I would argue, both epidemiologically and from trials, that there's few examples of heterogeneity in the treatment effect of blood pressure lowering, or so-called, interaction, whereby some group does, is different with respect to how they benefit from blood pressure lowering. And I think epidemiologically and in trials, there's really no consistent evidence that diabetics, patients with moderate to severe CKD, patients with history of stroke or CVD should be treated any differently than anybody else who's on a blood pressure medicine. So we tried to simplify this. We felt there was enough evidence to say that this target of 120 to 129 can be applied across the board, recognizing it's something that we say should only be targeted if the patient is tolerating it. And again, we're not talking about over 85 or frailty. There is one maybe caveat that we can certainly say is true, and that is that we don't have any evidence for pregnant women to go less than 140 over 90. And we can have a conversation about the CKD. I'm sure you guys will have lots to say about this. And, certainly that conversation was there for diabetes, but we felt there was enough evidence. And thankfully, in BP Road, which was the trial of intensive treatment in pure diabetics, which came out after this guideline, it just showed what we already expected from SPRINT and from the other trials that included diabetics. Sprint didn't include diabetics, but STEP did. The ESPRIT trial did, C or HCP did. And there was similar benefit in diabetics. There hasn't been, in fairness, a trial of pure CKD patients to these intensive targets. Sprint did enroll patients with low EGFRs, but not all low EGFRs. And Sprint also excluded people with an EGFR less than 20, I think, or maybe less than 30, end stage. How about resistant hypertension? God, I've gone on longer than I thought. Apologies. So the long story short, I've already said spironolactone, a beta blocker if they're not already on one. And then we gave a fairly weak recommendation for consideration of renal denervation, class 2B, which may also be of big interest to nephrologists. There's nothing wrong with renal denervation. It does work, but it's a fairly modest effect. It's probably 5 millimeters of mercury on out of office, maybe 5 to 10, depending on how you look at it. For invasive procedure, we don't have outcomes evidence that this procedure reduces cardiovascular disease. I think you can fairly confidently say it should if it lowers blood pressure, but there may be some off-target, things that mitigate the blood pressure lowering effect. And so we just don't know for sure. So in that context, given it's a procedure, it's expensive, and it's fairly modest effect, we did not, put it high up our treatment algorithm, class 2B, only in medium to high volume centers after shared decision making. We do say you can consider it for patients who are not resistant who are requesting it as well. And then the last thing is that we really wanted to emphasize what is something that is very obvious to people in the world of hypertension. That is that, the system is broken, and there's too many hypertensive patients and too few doctors to manage them. And doctors oftentimes have other priorities which are appropriate. This can sometimes be lower down the priority list, blood pressure, I mean. And there are a fair number of trials, including outcomes trials, that have shown benefit to patients with routine hypertension being managed by non-physician healthcare workers under protocolized, supervised collaborative care protocols. And we're trying to move in that direction a little bit. And somewhat provocatively for Cardiac Society and the Cardiology Guideline, we say 1A we recommend appropriate and safe task shifting away from physicians. I'll finish there. Thank you.
Well, thank you, Bill, for that great and precise and concise overview about that long and extended guideline. You mentioned the difference between US guidelines and the ESC paper. And some folks were wondering before publication of the guidelines if the ESC would equalize that target, and with review on those trials you mentioned, Sprint and ESPRIT. I mean, can you take us behind the scenes? Was there great debate, or was that clear? Did you fix that in 5 minutes or so?
Well, I suppose just so I'm clear. The last EU guideline, the 2018 guideline, the target was less than 140/90 in the first instance. And then they said for some situations you might go less than 130/80, whereas the US guideline in 2017 said less than 130/80. So there was a difference. The European guideline was more conservative in 2018. Our guideline from this year, from last summer, is more concordant with the 2017 US guideline, in that now both the European and the US guideline are saying the first target should be less than 130/80. We specifically give a range of 120 to 129, but it's not that different from saying less than 130. That was a very straightforward, easy, quick decision. There's no real debate about that. Obviously, there's a bit of debate in diabetics, some debate in CKD, and some reflections on how we can be pragmatic about this. Recognizing it's not always achievable, and that's where a lot of these caveats around frailty and age and and limited lifespan and the tolerance and having it as low as reasonably achievable came from. But the actual target, if otherwise possible, of 120 to 129 or less than 130, was a very quick decision.
And this target is always office blood pressure. So people shall take their blood pressure at home, but all targets refer to office attended blood pressure.
Yeah.
And the idea of unattended office blood pressure, which has been raised by Sprint, has somewhat fallen out of favor.
Yeah, the Sprint investigators looked at this. They didn't see a big difference between those who had it unattended or attended, but others have shown differences. I can believe there would be a difference if somebody had a blood pressure done in a quiet room without a healthcare worker compared to how we normally do it. But we just say for an office, we don't specify attended or unattended. That's partly why we gave that range. The other thing to say is that for, let's say, somebody has an office of 120 and a home of 120, we consider those equivalent, So 120 to 129 is fine as the target for either office or out of office. That's a lot better than what we're currently achieving, So, probably only about a third of patients with hypertension are actually at the 140, less than 140 target. So, if we can get everybody to 120 to 129, I won't care if it's by office or out of office. I think it'll be a huge improvement in where we stand. And guidelines can only go so far. They can't change people's behavior. And we'd like to think that they can change people's mindset a little bit if they read them and really thought about it. But we can't fix the problem with guidelines alone.
Well, that's an important. It's not so academic, but it's an important point in clinical practice because what you pointed out that there's a difference in diagnosis of blood pressure between home and office and ABPM, and then for the treatment target, it's a little closer together.
Yeah.
In fact, in a large outpatient clinic, you see a lot of patients that at least in my cardiology practice, we measure 150 over 90, and people and really show me their home blood pressure measurements with a decent cuff on 120 over 80, which is a much larger difference than the 10 millimeter mercury you alluded to. So what about these patients? I mean, do they all need 24 hours? What's the best blood pressure measurement, the best reading?
Yeah, the equivalence that we give, say, for home of 135, let's say, being equivalent to an office of 140, that's an average correlation, at an average level. But there's always got to be a huge spread, and there's got to be some people who have bigger differences than that, and that also may be attributable to white coat hypertension, which we're not even talking about here. We're talking about just routine blood pressure, what's the expected value on average in an average population based on a read in the office versus out of office. But yeah, I think if you have the out of office, the ambulatory, and it's in range, then I think that it would be, and that's what we say in the guideline, would trump the office.
Maybe one last, but I think really important question. You mentioned screening for primary aldosteronism, and I think this is really important because you mentioned the gap in treatment and the 20% or more patients that we lose if we do not screen. How opportunistic do you screen? Do you stop everything, or do you take renin and aldosterone just on top and don't do you really care for concomitant medication?
Well, I have a specialty clinic. I'm a general cardiologist, but also do preventive cardiology, and I have a lipid clinic, blood pressure clinic. But I also have a resistant hypertension clinic where we screen for secondary hypertension, and we also see young patients with hypertension. And in that clinic, we don't require patients be off interfering medicines before we do an AR or aldosterone-renin ratio, and we feel confident we can interpret many results based on what the meds are. But there are some patients who, once we've done a so-called dirty AOR, that's the word we use for when somebody's on interfering meds, if we're not happy, we'll take them off the interfering meds and repeat it as a clean AOR. But those are, less than a quarter maybe, or less than a third of the patients. And so, 2/3 to 3/4 of our, I'm talking anecdotally here. I'm not sure exactly what the numbers would be in the evidence, but I would say, at least in my experience, a good 2/3 of patients can be interpreted without stopping their meds. So I think it's worth doing in the first instance without interfering with their medications. And trying to interpret the ARR on medicines is generally not that difficult. Certainly if they're on renin aldosterone antagonists, you generally would expect that the renin should not be suppressed. And when you see it suppressed, it's very easy. Sometimes it's a bit more challenging, but yeah, we don't require them to be off the meds. And maybe about a third or so we ultimately do take off meds because we're not able to interpret the first test. And when I say 20%, I mean resistant hypertension patients. It's probably not as common in routine hypertension, but even in routine hypertension, depending on how hard you look, you might find it in 10%, up to 10%. So there's a lot of people out there with primary aldosteronism that have never been diagnosed. And, I think it's worth looking for because you can target the treatment and it's common enough.
Thanks a lot, Professor McEvoy. It was a great honor for us to talk to you and have a guideline author, the leading guideline author with us for this really important topic tonight. Thanks for coming. Thanks for being with us. And all the best for you. Bye-bye.
All right. Take care.